All right, good afternoon, everyone, and thank you for joining us on this policy forum where we will be discussing all things related to COVID-19 and asthma. My name is Carly Weeks. I'm a health journalist at the Globe and Mail, where I've been reporting on nothing but COVID for most of 2020. And if you hear some tiny baby noises, that will be for me. I have a tiny little baby with me, so just bear with me. And joining us today for what should be a really great discussion is Dr. Samir Gupta, who is a respirologist and associate professor at the University of Toronto. And, we're so lucky to have him today. And he will also be around to answer some questions at the end. So I'll be firing away, but then there is an opportunity for everyone to ask some questions as well. Before we get started, I just wanted to sort of set the scene here. We've all been living sort of this nightmare of COVID-19 for, the better part of this year, for all of this year. And it looks like this is not going to be over anytime soon. And, for people with asthma, this is something that affects them every day because while there's still a lot we don't know about COVID-19, we do know that people who have asthma are more likely or perhaps more likely to suffer from some complications and they have to take some extra measures to protect themselves. This is, obviously asthma is a condition that affects millions of Canadians. And this is something that touches people from, every part of the country. Not only are people with asthma more likely to suffer sort of complications or flare-ups as a result of asthma, their care may have also been disrupted as a result of COVID-19. Obviously, this pandemic has put a stop to a lot of the sort of normal health procedures and health treatments that were once sort of taken for granted here in Canada. And that's something we'll be diving into as well. So I'll kick things off by asking you, Dr. Gupta, just to maybe set the scene for us a little bit on what you're seeing in terms of how this pandemic is impacting patients with asthma. And also before he answers, there is a small conflict of interest declaration that you're going to give. So feel free to take it away.
Sure. Thank you, Carly, and thanks to Lung Health Foundation for inviting me to talk about this really important topic and raise awareness. A couple of conflicts I should probably declare is that I'm the chair of the Canadian Respiratory Guidelines Committee, which is the committee at the Canadian Thoracic Society that produces guidelines, and we may touch on some of the Canadian Thoracic Society guidelines. I co-chaired the Health Quality Ontario Asthma Standards, which are a really important standard that we may touch on as well in terms of quality of asthma care. I should also note that in my research lab, we've developed a tool called the Electronic Asthma Management System, the goal of which is to help primary care docs and nurse practitioners and respiratory educators and anyone in that sort of primary care circle of care to achieve better quality asthma care. So that's one of the tools that we've worked on, and I own the IP for that tool as it was developed in my lab. So that's just by way of conflicts. But in terms of as a broad question, I think that this pandemic has affected asthma in many different ways, the way that we care for patients with asthma. It's affected, obviously, the way that we care for all patients in that our workflows are dramatically different. But some of those changes to our workflows, in that we've adopted these virtual workflows more and more, have had a particular influence on our patients with asthma. And I would say one of the points to really delve into there is how the effect of a loss of access or a much reduced access to lung function testing has affected our ability to take care of our patients with asthma. I think that's probably one of the areas that I have felt the most as a practitioner, and I know that my colleagues have felt the same way. And on a policy and guidelines level, we've had to think about how to help folks through that, where we're not getting objective lung function testing at least as easily as we once did for our patients with asthma.
Tell me a little bit more about that. I mean, in terms of those tests, has that basically been sort of, there's no access right now, there's a backlog, and what kind of impacts do you expect we'll be seeing because of that for years to come?
I think so. If you break it down, we use lung function testing, particularly a test called spirometry, for two different purposes in asthma. One is for diagnosis, and the other is for monitoring and follow-up. So the diagnosis piece is an important one. There always has been, in most jurisdictions in the country, particularly in Ontario, there always has been a capacity problem. There's been somewhat limited access to these tests or longer wait times for these types of tests. And that is translated already into a few issues in the healthcare system. From the diagnosis point of view, we know that in fact, more than half of asthmatics don't get this test to make the diagnosis. You actually need the test to know for sure if someone has asthma, but more than half of asthmatics are diagnosed clinically, which means they're diagnosed on the basis of symptoms. But we also know that we're not all that good at diagnosing asthma based on symptoms. We really do need the objective test. There was some work done out of an investigator in Ottawa, Sean Aaron, who did a multi-site study across Canada and published a few years ago, a finding that if you take people who have been diagnosed clinically or in any way really by their clinician with asthma, a third of them do not actually have asthma when you test them objectively. And 80% of those people are on meds. So that's the kind of problem that gets exacerbated in a setting where you're in a pandemic and you're not running labs to full capacity. And to answer your first question, it's not zero. Labs are working at various different sort of percent capacities. But what's happening in labs is that techs have to be in full PPE, and there has to be a process for room air exchanges and for decontamination of all surfaces. That takes time. So most labs are at about 50% or less capacity. So you're having much less access to an already limited access resource in terms of diagnosing people properly. So you're probably having many more people being diagnosed clinically, which means many people are being labeled with asthma and even treated for asthma that probably don't have the condition. So that's one problem that's being exacerbated. The other point is that we use lung function testing for monitoring. And that's a really valuable resource to us because we ask about symptoms, but we also look at lung function, and sometimes lung function and symptoms are divergent. People feel well, but their lung function is down, and that's an indicator, according to our guidelines, for us to escalate therapy, to be more aggressive. Once we lose that tool, all we have is symptoms. So we don't know when we're missing folks who are having a decline in lung function. And what we worry about long-term there in losing our ability to monitor them as often, as closely, is the long-term sequelae of poorly controlled, poor lung function, maybe under treatment with anti-inflammatory therapy, which might translate into what we call remodeling or permanent changes in the airways, maybe translate into more acute healthcare events, because we know that drops in lung function translate into more emerge visits and more hospitalizations down the road. We're not as clearly and quickly able to get a handle on that if we don't have readily available lung function testing. So that's been a huge barrier for us.
It seems like that has the potential to be a huge problem that will basically haunt us for years and if not decades. Is there anything that we can do? I mean, this pandemic is basically here to stay. Even after we have a vaccine, it's not gone overnight. So are there things that people like yourself and others are thinking of? How do we manage this?
Yeah, there are a lot of different things that obviously as clinicians we're doing. We obviously are, all of us have adopted a virtual care workflow for many of our patients. The patients that absolutely need testing, we're figuring out ways to get them tested. And then we're adapting to virtual care workflows. Couple of different things that I think really are either emerging or are already here. And most of those leverage technology, and that won't come as a surprise to you. That's where we have to go. That's where advancement happens, and it happens more slowly in healthcare. But there are some technologies that I think are almost being pushed forward and validated more quickly and taken up more quickly, adopted more quickly, the same way that virtual care has been because of the pandemic. And examples I'll give, the first one, probably the most important one, is portable spirometry. So patients doing their own spirometry in the home setting, that's the one where there's been the most research. I can point to studies in asthma and COPD, validation work that has really looked at, how feasible is it to give a patient a spirometer, train them on how to use it, and then how useful are those data? If you say, look, you don't need to come in, you just need to blow in that spirometer, and either the data get transferred to me automatically, or there's a data output you could show me, it's on your phone. But either way, I get that information without you having to physically come into a facility with limited resources for that test. So that's something that's really exciting. We're actually doing a pilot at my hospital with asthma patients with that technology. There are other technologies that are emerging. There's oscillometry, which is another way to measure lung function. There's actually a portable home oscillometry setup that is early. It's in early development, needs validation. There's another test called fractional excretion of nitric oxide. So we look at this test not only for diagnosis, but also for follow-up and monitoring. And there's now a home version of that that needs to be validated. But if patients can blow into a machine and get their so-called FeNO levels, that also would be a game changer in terms of not necessarily needing that lung function test in that facility, that physical place where they need to go. The other piece is leveraging technology to help clinicians. A lot of the things that we want clinicians to do, even before the pandemic, they had trouble doing because we haven't empowered them with the tools, with the time and the knowledge on how to do that. And that's where I think technologies like the one I mentioned, the electronic asthma management system, technologies that are built to help clinicians to deliver evidence-based care, I think they have a growing role, particularly in a virtual care environment, where those technologies can be used virtually and patients can benefit from those improved quality of care pieces without physically coming into the clinic. And a good example of that is self-management. We want to empower our asthma patients to self-manage their disease. Conventionally, we've done that through paper. We've written what's called an asthma action plan and physically handed that to a patient and said, this plan will tell you what to do when you get sick. Well, that's really powerful, and studies show that it's powerful, but it's not used often in practice because it takes time and it takes some training that's just not done on. Clinicians don't have the training on how to do that, how to fill out that tool. And technologies, I think, one of them being the electronic asthma management system and others like that, that automate that process, that leverage virtual workflows and virtual exchange of technology to automate the process of, for example, creating an action plan and distributing that to, let's say, a patient's smartphone instead of physically on paper. It opens up a world of possibility for improving care in a virtual environment.
That is really exciting. And I have to say, we don't want to, like, there's not, if there's anything good that's come out of this pandemic, I mean, there's been so much bad, but any sort of silver lining or however you put it, this shift toward virtual care really has opened up a world of possibilities for, especially with a country with our difficult geography and how spread out everyone is. So that's, that is exciting to hear some of those developments. I wanted to ask about a subset of patients who, might be able to leverage some of that technology, but also, probably have to visit a lot more their healthcare institutions, and that's people with severe asthma. Obviously would require more care, more management. So has the situation with regard to COVID-19 sort of impacted them in a different kind of way? What can you say about that in terms of the disruption to treatment, care, follow-ups, and that kind of thing?
I think the first point to make about the patients in the severe asthma population is that the pandemic has had a much more profound personal impact, in my experience, in my patients with severe asthma. We have a growing evidence base on how SARS-CoV-2 interacts with asthma. So how folks who will come down with COVID-19 who have asthma will be affected by the disease. And what's been really interesting is that, generally speaking, asthmatics are overrepresented in diagnostic cohorts. In most studies, it seems that there are more asthmatics being diagnosed with this virus, but they're not overrepresented when you look at the folks getting sick from the virus. That's people who are hospitalized in the ICU or who are dying. So, and there are probably some interesting reasons for that. They may be overrepresented in diagnostic cohorts because many of the symptoms of asthma are the symptoms of COVID-19. You cough, you're short of breath, it's your asthma, but somebody says, hold on, you better get a COVID test. So they're probably tested disproportionately. The good news is that they're not getting sick disproportionately. And arguably, if you look at some of the data sets, maybe there's something protective about asthma. So if you look at the average asthmatic, they're at population level or under when you look at data sets of hospitalized ICU or people who died from COVID, which is a good thing. And there are some theories on why that might be happening. There's an ACE2 enzyme that is found in many cells in the body, including airway cells, that is the portal of entry for SARS-CoV-2. That enzyme is lower in asthma patients and seems to be downregulated by inhaled corticosteroids. So there's a putative mechanism, protective mechanism for inhaled corticosteroids in asthmatics, whereby they have less of this enzyme, so less of the virus can get into their cells. Maybe that's why they get less sick. So it's pretty speculative, but there are interesting reasons why this may be happening. The exception to that, I would say, though, is the severe asthmatic. So for most of my asthma patients, I'm saying, look, it looks like you're okay. The precautions that you have to take are no different than what public health is recommending because you're at no higher risk of getting really sick from this virus. But for my severe asthmatics with remodeled airways, low lung function, and particularly for the ones on steroids, because those folks are immunocompromised. Those are the patients where I'm still saying, listen, I am really worried about the consequences of an infection in you. And for those patients, it really has meant for, in terms of dealing with the pandemic, it's meant not being able to go to work. In many cases, fear, justified fear of not being able to leave their homes, a much more impactful effect on everyday life. And so really tough for these people with impaired lung function and who are often steroid dependent. And I also worry much more, like you said, about the consequences of not being able to measure lung function as regularly in these folks and anticipate flares, because flares can be so consequential in our severe asthmatics. Flares can land them in the ICU. Flares can lead to prolonged hospitalizations. And those are the patients in whom we, as you say, we're more vigilant. We see them more often. We're doing the best we can, but of course, we have, we might be doing lung function testing every 6 months instead of 3 months. And there will be a cost to that. And some of these patients will flare in between. We empower them with tools like action plans. We empower them with, education. We see them virtually, but the lung function piece is what we're missing.
Yeah, and I mean, like this and so many other conditions, you just worry about what lies ahead for a lot of these patients. So I'm sure there's, definitely a lot of trepidation about what's going to happen over the second wave and the coming winter as well. Perhaps on a sort of a more maybe a more upbeat note, you're involved with Health Quality Ontario. What do you think? Maybe there's something like we've learned with moving to virtual care and technology. Does this pandemic also show that there is a need to maybe develop better or implement more of the quality standards that have been created and make sure that those are being sort of adhered to and followed, improving sort of those benchmarks for treatment and that kind of thing? So what would you say about that?
I think we've done a lot of benchmarking. We always have, and benchmarking involves looking at guidelines, looking at the evidence, and understanding what is best care. It also involves looking at what is current care and where the gaps are. And Health Quality Ontario has been a leader in that, and I applaud that agency for doing that across diseases and giving practitioners a roadmap to what you ought to do and what will lead to better outcomes for your patients. The challenge is that that's what guidelines have done for years. And I'd say HQO standards are sort of a better way to disseminate those guidelines. But we haven't done the last piece, which is implementation. And if you listen to the clinicians, they'll tell you guidelines for chronic disease management are complex, including asthma guidelines. And there are many barriers to following that advice. It's not just knowledge. The idea that if you educate, if you do continuing professional development, if you put this information out there, people will just follow it. That's been invalidated by a stack of literature this high. So it's time for us to really think about what are the barriers, and barriers consistently have to do with having enough time, particularly in primary care settings where most of these patients are seen. It has to do with training and knowledge. It has to do with remembering to do certain things at certain times. So I think we really do need to empower people with the tools to follow through on the quality statements that we recommend. And if you look at the Health Quality Ontario standards for asthma care, there are 6 core things, 6 core principles. They say that you've got to diagnose the disease objectively. This comes back to the first thing we talked about, whereby we're overdiagnosing. Let's make sure we got the right patients. You've got to assess their control according to guideline criteria. There's a slide up now that says 93% of prevalent asthmatics, according to this survey, don't have good control of their disease. Yet 92% think they are well controlled. There's an underperception. Patients have low expectations of asthma control. You need clinicians to ask them the guideline-based control questions to uncover their poor control. The third one says you've got to get them on the right drugs. You've got to get them on the evidence-based therapies for their level of control. We're not good at doing that, partly because this is a changing landscape. There are a lot of drugs on the market. There are a lot of devices. It's confusing. It's challenging. It's changing. The fourth piece in the standards say that you've got to empower people to self-manage their condition. Every patient should get an asthma action plan. Every patient should be told what to do when they get sick If you do that, they'll come to emerge less, they'll come to hospital less, they'll have a better quality of life. We know all that. Got to do that. Not easy to do, but we want people to do it. The fifth thing is we want to know who the severe asthmatics are. These are the really sick patients that eat up a lot of our healthcare system's time and resources. We want to get those people to specialty care so that we can get them on the right therapies, more aggressive therapies, often biologics and others. And the last one has to do with follow-up. When someone does go to emerge or gets hospitalized, within a week at most, we hope that they can see a healthcare provider, particularly because they tend to be coming off their acute care therapies like prednisone in that time span, and you want to make sure they're okay. So there are 6 standards, and the challenge is, how do you actually enable a busy primary care doc to do those things, or even an asthma educator who has a large roster of patients to do that for? And that's where tools, I think, electronic tools, virtual care tools, technologies like the ones I've mentioned would really help clinicians, because you've got to identify their barriers and you've got to identify strategies that then target those barriers. You can't just say, do these things, this is the right thing to do. Everybody would love to do the right thing, but to bridge those gaps, you've got to give them tools. So I think that's where we've got to go from creating standards to creating implementation tools to empower clinicians to actually fulfill those standards.
That's often one of the big challenges, you speak to, busy primary care practitioners. So, are there sort of proven ways or other, sort of diseases that we can look to and say, this is how they were able to implement those changes, for clinicians who are just, sort of run off their feet already, anything or strategies basically just to try and help ensure those do get implemented into practice?
Yeah, there are a lot of different behavior change strategies. That's what implementation science is. There's the science of behavior change, and it really starts from understanding barriers. And I would say that what we can learn from other diseases and what we can learn even from work that's been done in asthma in Canada and in other jurisdictions is that you start with understanding barriers. Barriers are different in different diseases. In some diseases, it's about knowledge. In other diseases, it's not. Practitioners know the right things to do, but they don't have time, for example. In some cases, it's not just about time, it's about practical things like workflows. It just doesn't go into their workflow, whatever task you're asking them to do. Sometimes that's not the standard. That's not what my colleagues are doing. And so things like, leveraging key opinion leaders, leveraging something like audit and feedback, where people can really understand, oh, what are my colleagues doing? If most of my colleagues are doing this, maybe that does motivate me to change practice. But I think ultimately you've got to, particularly for the complex behaviors that we want to happen for asthma patients, you've got to have tools that embed knowledge, because knowledge remains a barrier in terms of how to actually do these things. And tools that do these things really quickly, because time is at a premium, and time is what a lot of these things take. It takes time to ask all the control questions. It takes time to fill out an asthma action plan. It takes time to consult the guidelines and figure out where you are in the medication algorithm. And an example I'll give you again is this tool that, one example is the electronic asthma management system, that it tries to address the time piece by getting patients to complete a questionnaire. So a lot of the data collection is done on the patient side. And then it tries to address the knowledge piece by leveraging algorithms that are built on the guidelines so that clinicians are getting advice pushed to them. And then it tries to address the workflow piece by integrating into the electronic medical record so that when you open the chart, you're getting the advice for your patient at that moment. That means what's their control, what should their meds be according to guidelines, and then auto-populating that asthma action plan. So right away, you see how many of these challenging complex behaviors that are in the standards, you can address them if you engage the patient. So the patient is our ally, and a lot of asthma patients want to be engaged in their care. Get that ally engaged, get that patient to give you some of the information that's going to make your workflow more efficient, and then use technology to enable those workflows. We have technologies that can do this. We've got to get them out there. We've got to get people to believe in them.
Yeah, I wanted to ask you about that, like the asthma action plan, because, patient engagement and empowering patients, it's a buzzword, but, with good reason. Like there are things that, patients can be empowered to do to help manage their conditions. And, Like, it sounds as though that is maybe a really big under-leveraged resource in this whole situation, especially maybe now COVID kind of really brings that message home, perhaps.
Yeah, I think, it's funny because when we talk about all these care gaps, a lot of times we'll get some pushback saying, listen, this is not the time to think about chronic disease management. We're really busy with all these new COVID workflows and PPE, and it's a challenging time. That was fine for the first few months because we all hoped it would go away somehow, or there would be a miracle vaccine, or something different would happen than what's happened with previous pandemics. But obviously that hasn't happened. We know this is here already. It's been here for a long time, and it's likely going to be here for a long time to come. And so the reality is that we're now seeing the consequences of missed opportunities for chronic disease management. And an asthma action plan is a really good example, because what we say to sites who say, well, we don't have time, this is a chronic disease management thing. Is it really that important at a time where we're dealing with a pandemic? And the answer to that is, what an action plan does is it empowers a patient to self-manage worsening asthma symptoms. Like we said earlier, worsening asthma symptoms are exactly the symptoms that will land you in an urgent care visit with your family doc, that'll land you in emerge, the exact settings we don't want patients going because they're overloaded with COVID. We would love patients to be able to self-manage and avoid that visit. So there's the first point. When you have an overloaded health system with all these patients who require visits for COVID, COVID testing, et cetera, we want to keep people who have chronic disease out of the system if they can self-manage their flare-ups. The other piece that's really challenging is that these asthma flare-ups are very similar symptom-wise to COVID. So if a patient can't get their exacerbation under control, guess what they'll need when they go to emerge? Every single one of them is going to need a COVID swab, because they tick the boxes for COVID symptoms. So not only do you have a run on the system in terms of capacity with respect to visits, but you will also have a run on a very limited testing capacity system in our system right now. So the kinds of things that we can prevent with asthma action plans are the exact kinds of things we're trying to preserve and prevent to maximize our capacity to take care of COVID patients. So there is a synergy there where there's almost a stronger case in the context of a pandemic to optimize self-management tools to keep those people out of the system when the system needs all the capacity it can get.
Sort of a related point to that, just going to a question from one of the audience members, self-management of disease is obviously very huge. And, we're talking often some complex medications, treatment plans, things like that. And so has COVID-19 impacted in any way the ability of doctors and pharmacists to properly communicate those things? I'm thinking there might be a lot of particularly vulnerable older patients who may not be able to use technology as well, things like that. Are you seeing anything like that?
Absolutely. I mean, these technologies are very useful for the sort of 90% of people in the country who have a smartphone, but we don't want to forget about the 10% who may be in a different age demographic, who have less comfort, don't have the device, or have less comfort with the device, particularly for something as important as healthcare. I work in an inner city hospital, so we also deal with a lot of patients who don't have the means, who don't have the internet connection, they don't have the computer, they don't have the phone. How do we help those folks? Those workflows are even more challenging because we can't leverage virtual care. Those are the patients that we really worry about falling through the cracks. Those are the patients that we're often saying you have to come into the office, you have to come into the clinic, we have to do your breathing test, I have to listen to your lungs. Because either you can't do the virtual care visit, or you can't do it with the quality and reliability that you need to do it with. So those are the patients we worry more about. And they're vulnerable in different ways. And unfortunately, they're also often, particularly the folks who are of lower socioeconomic class, who are in more challenging housing situations, income situations, those are often the folks who have poor asthma control, because unfortunately they have less stable access to meds, they have less well-controlled environments in terms of their asthma triggers. So they're the very patients we worry most about, and they're the very patients that we have more limited access to in virtual care workflows.
Okay, thank you. The next one is more of a sort of a comment than a question, but it's a good one. And basically that there are healthcare professionals trained as respiratory educators who could perhaps bridge some of those gaps. And you know, all of those things that we talked about, all of the missing gaps, they might be able to fill that. So that is maybe certainly something that could be done moving forward, perhaps.
Yeah, I mean, it's not like it's not being done. Respiratory educators, and I work with three of them in my clinic, and they're sort of I don't know how I do my job without them. So they're a critical resource in this battle to improve our quality of care. But the reality is that they're a limited resource. They're run off their feet. Many of them are serving 5 clinics and trying to help all the patients across those clinics. And asthma is a common disease. There are 3.8 million asthmatics in this country, and the reality is that the resources we have for respiratory education can't meet the need. In many cases, they're seeing tip of the iceberg. They're seeing the sickest patients. They're not seeing all the patients who need chronic disease management optimization. So I think we need to empower those folks with tools. I think these electronic tools are just as potent, maybe even more potent in their hands, because instead of seeing 5 patients at that clinic on that day, you can see 20. If all the patients have done a questionnaire in advance and you're getting automated asthma action plans, automated advice into EMR, your workflows will be more efficient. So that resource person who's an expert in asthma care can leverage that technology even better than the average GP who's seeing 20 different conditions. So I love that resource. I think I would love to see more investment in that resource, but I'd also love to see use of technology to enable that person to do their job more efficiently and to cover more ground.
Thank you for that. That's really, you know, important to know. And wanting to jump into a bit of a hot button issue before we go to a couple more audience questions. And of course, that's masks. And, you know, but seriously, there are some concerns that people with respiratory issues, such as asthma, it may be more difficult for them to wear masks. What are you seeing? What does the research tell us? Are there risks that people with asthma need to keep in mind?
Carly, this is really important. It was important enough that myself and some colleagues at the Canadian Thoracic Society put together a position statement on this close to the beginning of the pandemic, and that position statement will be updated soon in light of growing evidence. But the most important point to make, which I make with my patients too, is that there's really no evidence that wearing a mask will trigger or flare your asthma. It will not cause you to exacerbate. The other piece is, well, what about just the discomfort? What about breathing through a mask? You already have lung disease. Now you have to breathe through this barrier, this mask. So the good news is that there are some studies. There are some data on this. Some of this was just reviewed recently. And what we've learned is that there is very little resistance to airflow through a typical mask. A lot of the studies are done, in fact, in the more prohibitive, more tightly filtering N95 masks, ones which we don't see people in the population wearing. We don't want them to wear. So it's even less so in your cloth mask or your basic surgical mask. There's very little resistance. And studies show that even with light to moderate exercise, there's no change in ventilation. There's no change in work of breathing, what we call, which is the effort the patient has to make. So those are very reassuring studies. We even have some studies in patients with severely impaired lung function. Most of those studies are in COPD rather than asthma, but those are patients who have generally lower lung function than asthmatics. And those studies show that even with exercise, light to moderate exercise in patients with significant COPD, wearing a mask doesn't change carbon dioxide, doesn't change oxygen levels, doesn't have a significant impact on their ability to exercise, which is really reassuring because the base case scenario is just wearing it at rest for most people. And what we're finding is that the studies show us that even with exercise, we're not seeing important physiologic effects from face masks. And that is something that we're constantly reminding our patients that it may feel uncomfortable, and for sure there's a perception of dyspnea that comes with it, and for sure there's an anxiety piece, and we have to allay those anxieties, and sometimes patients just can't do it and have to take it off and have to be in an environment where they're otherwise safe and distanced if they have to do that. But I think hearing that and understanding that there's an evidence base to say you're safe, don't believe what's on the internet. Your carbon dioxide levels are not going to go up. Surgeons have been wearing masks for 10-hour surgeries for centuries. They don't faint on the surgical table. We've been wearing masks in our profession from the very beginning, and it's fine. And patients will be fine too. The data support that. And I think hearing that goes a long way in my patients to say, you know what, this is okay. And also, by the way, particularly for my severe patients, you're the exact patient that I want wearing a mask. You're the person I want protected more than anyone else because you're most susceptible to a severe outcome from this virus. So on both counts, you're safe to do it, and you really need to do.
Okay. I wanted to quickly touch on as well something that a lot of people worry about, and that's, say the risks to kids in school, thinking about, for instance, some people, if children have asthma and they're in a classroom where there is a lot of sort of disinfectant product being used, that kind of thing. I'm sure you've been hearing a lot of questions about that. So is there anything reassuring that you can say on that front, or warnings, I guess?
It's a tough one, Carly. For lots of obvious reasons, we want to disinfect surfaces, particularly in schools, where all those little hands are touching everything. And we have to do that. But unfortunately, a lot of the disinfectants that we have available to us have a volatile component, and that volatile component can be very irritative to our kids with asthma. The good news is that we're doing this in the context of a pandemic, but there are also other measures we're taking in the context of the pandemic that are going to be protective against asthma flares caused by these volatile chemicals. One is that we've, in many settings, improved ventilation. Schools have improved ventilation to reduce aerosolized SARS-CoV-2, but at the same time that improves dispersion, clearance of these volatile chemicals. The other thing we're doing is that our kids are wearing masks in school, so that reduces exposure as well. Both of those are protective against these volatile chemicals that are being used for disinfection. The other piece is that I think folks are cognizant of the fact that, you find the best time to do this. For example, when the kids are on recess, you find a time where there's enough time between when this is sprayed, when this is done, and when the kids come back. And hopefully for the children who do have asthma, you take extra precautions. You build in some extra time, and you try to develop an understanding of what do they react to, what do they not react to, and how to manage that in those specific circumstances.
Okay. So we only have a couple of minutes, so we have a few more questions. So maybe we'll breeze through these quickly. I mean, very important topics. I mean, one that I'm sure you've been hearing about this as well. COVID-19 has had a massive impact on people's employment, their financial well-being. So are patients struggling to pay for those prescriptions that may not be covered otherwise?
In some cases, we're seeing that. As you know, the coverage is pretty piecemeal. It's different in every province, and in our province, it depends on employment status. It depends on income level if you're on Trillium, and it depends on age, right? So some of the patients who are covered are still covered. None of that has changed. Some of the patients whom we always had to support with other ways, like patient support programs, samples, et cetera, we're still having to support in that way. But it's challenging because we're having to have them physically come in, because their way of getting their medication was to see us and for us to hand them a couple of samples until the next visit. And we can't do that virtually. So that's posing a challenge. And of course, the economic hardships of the shutdowns associated with the pandemic have an impact on disposable income. And unfortunately, there's shelter, there's food, then there's medicine, right? So some people can't afford it. You've got to have a roof over your head. You've got to feed yourself, and then comes controlling your disease. And for some people, they just don't get there. And so that's a really challenging thing to do. We're trying our best to support our patients through it, but we don't always have the answers. We don't always have the solutions to that. We're waiting for an national pharmacare plan, very much so.
Yeah, that's really what we need for sure. And of course, fortunately, that also has been put on the back burner because of COVID-19, it seems. Is there any evidence of biologics that are able to help asthmatics who get COVID-19? That's another question.
Nothing that I've seen in the literature. Again, we want our asthma patients to be well controlled. We had a position statement of the Canadian Thoracic Society on management of asthma in the context of the pandemic. Nicole's notes version of that is do what you were always doing. Do nothing differently, meaning keep your patients well controlled. The better controlled they are, the less likely they are to flare, whether from COVID-19 or irritant triggers like cold air or allergens or other viruses. We don't want them flaring, which means keep them under good control. That means keep them on anti-inflammatory meds. And for the severe asthmatics, it means get them on biologics for that small proportion of patients that really can't get under control with more typical inhaled therapies. We do need biologics, and we absolutely want them under control. We also ideally want them off immunosuppressive medications in the context of a pandemic. If we can get our patients off something like prednisone, which weakens their immune system, by getting them on a biologic, then there's a benefit there in terms of how worried we are about them contracting this virus and getting really sick because their immune system is compromised.
Okay. There's a comment that just noting that the Lung Health Foundation does actually have a free lung line that's answered by a certified respiratory educator. So that's an amazing resource for people who may be in one of those areas without one, or not able to access, because as you mentioned, respiratory educators are in short supply. And this, it might be a good question to sort of end on. Um, we now have good reason to believe a vaccine is on the way at some point in the next many months. So
Two vaccines.
what about, how could that impact people with asthma who may not be eligible for that vaccine? Basically, will they just have to simply wait this out? When can they return to in-person medical appointments and that kind of thing?
Yeah, it's really exciting what we've heard from Moderna and from Pfizer in the last week. Obviously, we want to see the trial data, but I have little doubt that the trial data will pan out, because these are going to be the most scrutinized data in the history of scientific publications, I'm sure. So I think these companies would probably be ahead of that. And we're probably going to see what they're saying we're going to see, which is really encouraging. Then the next question becomes, who gets this first? If Pfizer makes 1.3 billion doses in 2021, and there are 8 billion people in the world, and hopefully 60–70% of them agree to get it, we won't have enough. And Moderna's going to make a lot less. So who's front of line? I think that's the next big debate that we have to have. We probably should have had it earlier. What constitutes an essential worker? What constitutes an at-risk patient, and who's most at risk? So as I said, based on the data we have now, most asthmatics are not at a higher risk, it seems, of severe outcomes from COVID-19. That means that they won't necessarily be prioritized in the same way that we may be prioritizing COPD patients, diabetics, hypertensives, patients with obesity, cardiovascular heart disease. So what that means is they will probably be getting the vaccine, all other things being equal. If they're not essential workers, for example, they'll probably be getting the vaccine at the same rate as the population is getting it, through whatever mechanism we work that out to be. And so I think we're in for some of these virtual care workflows and some of these workarounds for some time now, for at least the mild and moderate asthmatics. For the severe asthmatics, there may be an argument there for earlier vaccination. We don't have the data yet, but I think there's a mechanistic argument to be made. But TBD, how we roll this out, who gets it first and what those thresholds are, who's assigned that difficult task of figuring that out. No matter what, someone will feel slighted, someone will feel prejudiced in how we roll this out. It has to be transparent. It has to be publicly sourced. So let's see how that works out.
Yeah, that's a fantastic point. And, I think we're lucky to be in a position where, we're actually talking in real terms about a vaccine, but yeah, many, many difficult discussions to come. So with that, I will draw this discussion to a close because we are a few minutes over, and we just really appreciate your time. There's been, a lot of questions. So obviously this is something people are really, really tuned into. So thank you so much for your time on this subject. I'd also like to thank the sponsor for this event, AstraZeneca Canada. And yeah, please stay tuned, folks, for the next one we'll be doing later in the month. So thank you all for joining us. And thank you again, Dr. Gupta.
My pleasure. Thank you.